Hello people. So, lung abscess. It basically represents necrosis and cavitation of lung tissue following a microbial infection. When it comes to the microbes, it can be any microbe that comes to your mind, especially bacterial. So many bacteria can cause this cavitation. Staph aureus, pneumococ, Klebsiella, anaerobic pathogens, or all of them together in a mix, multimicrobial etiology. All of them have the possibility to cause a complication, for example, of a lung infection of lung parenchyma or pneumonia, is obviously the possibility to develop an abscess. So an abscess is this newly formed cavity in the lung tissue that has elements of tissue, necrotic elements, inflammatory cells, and it is the result of a complicating infection. Basically, lung abscess is classified into two big categories. The first one is the primary lung abscess, so the primary one. And the other one is the secondary lung abscess. Basically, when we are talking about a primary lung abscess, we are talking about abscess developing in the lung, but there is no underlying setting, no underlying condition that predisposes the lung to develop an abscess. So no underlying condition. Or setting. Basically, for example, aspiration is one of the primary causes of lung abscesses, and aspiration happens in alcoholics. So alcoholism, or basically aspiration, is the most common cause, the most common condition predisposing a patient for a primary lung abscess development. What happens there? Basically, people who drink a lot of alcohol, they have this tendency to vomit because our body thinks, our brain thinks, our receptors thinks that the alcohol, if it is ingested too much, is a toxin, and it tries to get rid of it through vomiting. But if people are too much intoxicated, the epiglottal reflex to shut down the larynx is slow to react. So when alcoholism is present, and when people drink too much alcohol and they start to vomit, the epiglottis doesn't close that fast, or they are in a coma, and acidic stomach content, so vomiting, and this acidic stomach content gets into the lung. So it enters the lung, and this is corrosive fluid. Together with bacteria, it destroys the lung tissue, bacteria settle, and we have a perfect possibility for lung abscess to develop. And also alcoholics have a impaired immune system. So this is when it comes to primary abscess, which is 80% of abscess we see is a primary abscess developing when there is no underlying condition. Most common mechanism is this one. Obviously, there are others. There is a possibility when people have an altered mental status, they can also aspirate fluids. Also, for example, what other seizures? People who experience seizures also have this possibility to aspirate fluids. Drug overdoses, coma, obviously also aspiration of fluids. So this is the primary mechanism where we have no special underlying setting. We aspirate something and then lung abscess develops. When we talk about this secondary lung abscess, 20% of cases, so basically there is some underlying setting, underlying condition that predisposes the possibility for for a lung abscess development. For example, a tumor. Tumors have this possibility to destroy tissue, make necrotic tissue, make obstructions, and that is a possibility, a good breeding ground for bacteria colonization. Also, foreign body. If there is a foreign body in the respiratory system, it is the same like a tumor. Also, tuberculosis, it can form its own cavities, but it can weaken the immune system of the lung enough to predispose for also other bacteria to make their problems. Also, any disease that weakens, like HIV and any other disease that weakens the immune system, predisposes for pneumonia, and pneumonia is also an underlying condition that can have so pneumonia is also an underlying condition that predisposes obviously for lung abscess development. There are some conditions that are sometimes mentioned separately that also cause lung abscesses. So these cause the majority, especially this one, but also septic embolization. So septic emboli. And septic emboli can come from thrombophlebitis and endocarditis. So thrombophlebitis, bacteria from there and from infection in the heart hematogenously can move and go to the lung and cause septic embolizations, pneumonia, and then abscess formations. Also trauma. So obviously trauma, for example, to the chest wall opens up the skin, and protruding to the skin bacteria cause pneumonia and then abscess formation. But as I said, the majority is caused by this mechanism. Now, what is the clinical picture of an abscess? This is similar, so obviously in all of these etiological possibilities. So the abscess is basically a huge inflammation in the lung. We will have fever. With fever, we will have also chest pain. Because a big part of the lung is involved, there will be shortness of breath. Then also fatigue. Every of these conditions involving the lung lowers our capacity to exchange gases, so fatigue will be surely there. Night sweats. Night sweats are especially something we see often, for example, in people who have tuberculosis. They are subfebrile, they are very skinny, most often they are have some predisposing condition, for example, alcoholism, bad diet, low hygiene, and They have night sweats, they are subfebrile, skinny patients, and they have these lung tuberculosis. Also, in lung abscess that is caused by this mechanism, so aspiration, alcoholism, watch out for the presence of gingival disease. It has been associated with the possibility for these bacteria to go from the mouth down into the respiratory system. A very big point in lung abscess that is not similar that much to pneumonia. So most of these you would have in pneumonia and tuberculosis, most of them. But in abscesses, almost 2/3 of the patients have a foul smelling, purulent sputum or mucus. So this is something interesting in these abscess formations. When they connect with the bronchi, people start producing these foul-smelling mucuses. Also, an important fact is that older people, where you do an examination and find an abscess of the lung, in 10 to 15 cases, which is not a low percentage, it is connected to carcinomas. So you need to watch out for a possibility for malignancy if you see in older people a lung abscess. Now, the diagnosis of these, so this would be the clinical picture. So the diagnosis of lung abscess is basically, in any patient we do patient history, a physical examination. We would also do lab testing. We would definitely see elevated CRP, elevated sedimentation, and so on. But when you do an X-ray, you will see a cavity. And to evaluate the cavity, its surroundings, and the chest and the lung, the best thing is a CT scan. So it will give you a good representation of everything. Also, the sputum analysis. The sputum analysis can give you the causative agent of the problem. So this would be the diagnostic in simple terms. Now, also, when it comes to the therapy can be complicated, can be provided by many different combinations of antibiotics. One antibiotic that has proven its value in many, let's say, uncomplicated cases, for example, is clindamycin. It is initially given 600 milligrams intravenously 3 times in 24 hours. So it is given in this way until there is no fever. And when we see that the patient is getting better, if we see a clinical improvement, then we start giving it 300 milligrams 4 times in 24 hours, peros, so through the mouth. And this is given for a longer period of time, so it can be given 3 to 4 weeks. So this would be a good treatment most patients will respond to. Now, what if we would take this cavity and expand it a little bit? So we will take this cavity that is formed and expanded. The cavity has this central part, which is filled with neutrophils, dead bacteria, so plus dead bacteria, and exudate. So basically it is necrotic tissue in here and our immune cells trying to fight everything off. The outer layer is this fibrous layer where we also have many fibers starting to be secreted by fibroblasts and also immune cells trying to contain this problem. And at the outer edges are some remnants of lung tissue. These are actually alveoli that are filled with neutrophils, with red blood cells, some bacteria. After there is a resolution of the disease, so after this therapy, if we do an X-ray or CT, we will see a scar or a complication. So we can have a scar, or for example, we can have complications. If it was a big abscess, it can lead to the development of a pneumatocele. So a pneumatocele is nothing else than a lung cyst. And this is a problem because it predisposes the patient to another infection. Another complication is the development of empyema. The development of empyema. So the difference between empyema and abscess. Empyema is pus in an existing anatomical cavity. And abscess is pus that is formed and existing in a newly formed cavity. As this abscess breaks up, for example, into the normal anatomically present pleural cavity, we can have a complication called pleural empyema. So these are some of the possibilities. Lung abscess has been a grave problem in the time when we didn't have antibiotics. Today, the mortality is going down because we have adequate treatment possibilities. Thank you.